With that, let me turn to our expert moderator, Rachel Nuzzum, who actually is a Vice President for Federal and State Health Policy with the Commonwealth Fund. She is not only an expert through her work there, but for at least a couple decades has been doing health policy on various levels, including with Congress and even Governor Roy Romer in Colorado. So with that, let me turn to Rachel. Thanks.
Thanks, Dick, and thanks to the NCSL team. Thanks to all of you for being at a session that offers CLE credits at the end of the day. So that is very admirable, and congratulations to that. For those of you who are feeling a bit out of breath or just trying to keep up with the recent developments in the insurance markets, you're not alone. All of us spend a good amount of our time in our day trying to keep up with the regular developments, and it is literally a full-time job, and we're here to make sure we can walk through and answer any questions anyone has. From repeal of the individual mandate to debate around pre-existing conditions, from AHPs to STPs, and don't worry, you'll know what all of those are if you don't know what they are already by the time we're done. From the administration actions to state policies, from court cases to our on-again, off-again relationships with the cost-sharing reductions, it's all fair game today, and we're going to try to address all of those issues and likely more in 75 minutes or less. This issue of ensuring access to affordable, high-value care is squarely in line with the mission of the Commonwealth Fund. Our mission is to really bring evidence and analysis to bear and to help inform policy making and policy deliberations that you all are engaged in every day, that your colleagues are taking on. And again, we're really focused at both the federal and the state levels, along with our private sector partners. We have a tremendous panel to help us address these issues today. But remember, this session really is for you all. I know it's a big room, but I know we all have big voices and microphones. So we want to make this workable for you. We want you to ask the questions that you really need answers to, and to make this interactive. So we will meet you there, and please engage. And we also have a tremendous panel to help us address these issues. And I'm just going to do very quick introductions because you've got their impressive bios in your background material. We're going to start with Dr. Shuizawa. For those of you in the Medicaid session, he probably looks familiar from this morning. Dr. Shuizawa is the Regional Director for HHS in Region 8. He leads a Denver-based office as the personal representative of the Secretary of Health and Human Services. He's a former legislator from Utah. He's been on governor's task forces. He's an expert. He's an expert in both clinical medicine as well as policy, and we're thrilled to have him here today. Then we're going to hear from Brian Webb. He's the Assistant Director for Health Policy and Legislation for the National Association of Insurance Commissioners. So he really has a really good understanding and insight into what's happening across all 50 states. Brian's got experience in Congress, as well as the private sector, and we're thrilled to have Brian on the panel with us as well. Then we're going to move to Justin Giovanelli from the Georgetown Center on Health Insurance Reform. He's a researcher that's been doing an incredible amount of research and writing, generating a number of tools for state and federal audiences alike. Thanks to Justin for being here. And then finally, Leanne Gasaway, Vice President for State Affairs for America's Health Insurance Plans, or AHIP. As most of us probably know, that's the National Trade Association representing over 1,200 insurance health plans, covering more than 200 million Americans. She's responsible for assisting in legislative, regulatory, and policy efforts in the states and activities at various political and regulatory organizations. We're thrilled to have Leanne join us as well. So with that, I'm going to turn it over to Dr. Shuizawa.
Give us one moment with the PowerPoint, sir.
Well, good afternoon, and it is good to rejoin you. For those of you who did come into the Medicaid session earlier this morning, for those of you who haven't, I was, as I alluded to this morning, privileged to be part of this audience last year in Boston when we also participated in the NCSL program. And let me give my personal thanks to NCSL for their leadership in terms of these many important issues, and also their publications, which make for real good reading in terms as a policymaker. Now, as a physician, I figured I knew a lot about this, but the regulatory and the policy side is something that is so crucial to understanding, not only if you're in practice, but also for those of us in the who are or were in the legislature in terms of policy and regulation and designing the very best policies for our constituents. So this is just a quick overview of HHS. You see there's a number of different agencies and their approximate number of FTEs and their budget allotment. These are your taxpayer dollars hard at work. And you can see that clearly CMS has the majority of not only the funding, but will have that majority as you go forward. Now, the Office of the Regional Director, I'm one of 10 regional directors. I'm based in Denver, and for those of you around the country, you can see your own region. But my region has the great states of Colorado, Utah, Wyoming, Montana, North and South Dakota. Now, Secretary Azar has 4 important priorities, and I want to allude to those. And so you say, well, wait, I thought this was a talk about insurance. Let me posit to you that these are all related to insurance. And to understand these is to understand better the insurance. So we clearly have an opioid crisis. We see it now, we see it personally, we see it across the country, we see it in our own states. We also know that there's a huge cost in lives and in economic value. We're going to talk about health insurance reform, but we also need to talk about drug pricing. Not only list prices of drugs, but availability and also out-of-pocket costs. And then finally, value-based healthcare. And what does that mean? For example, does value-based healthcare mean paying instead fee-for-service? Right? You pay for procedures and things that doctors do, but rather now encourages pay fee for value. 170 people we know die from drug overdoses a day on average in this great country of ours. And as you see in blue, this was in 2006 in terms of the incidence of the drug abuse problem. And you can see as it's gotten considerably worse in terms of colors as we see just a few years later. Now, I want to point to this particular slide because it illustrates not only are we seeing overdoses going up in general, but you see the red line with synthetic opioids. We're talking about things like fentanyl, which, as you know, if you work in healthcare industry or you've seen this personally, is a killer. This isn't just an overdose. These people die before they get to the ER, and if they're fortunate enough to get to the ER, oftentimes they have neurologic injury, and it takes a lot more Narcan to resuscitate these patients. And even if you can treat these people, the problem is fentanyl is out here in such counterfeit quantities and qualities that it's marketed under things that people thought were maybe oxycodone or MS-Contin or something like that, but it's actually far worse because the fentanyl is so much more potent and so much more deadly. And I know each of you have reviewed this in your own states. The CEA, the Council of Economic Advisors, about 500 billions in 2015, we think, both in fatality costs and non-fatality costs. This is a huge cost, and it affects your economy, it affects our health insurance. You know that because your premiums will go up as a result of this, not only in treatment of patients, but also in terms of prevention and recovery. Now, in terms of drug pricing, the Secretary has identified 4 major challenges: the high list prices of drugs, seniors overpaying for drugs, and high out-of-pocket costs, as well as potential foreign governments free riding on American investments in innovation. And so as a result, there's some proposed remedies for this, such as improved competition, better negotiation, and incentives for lower list prices. And I want to just say that we're grateful to the pharmaceutical industry for freezing, many of them, list prices for this year, and look for even lowering of those same prices as we go forward. So look at this drug pricing. You know, in 1980, you can look and see what that figure is and how much more it has increased. And this graph is unsustainable. I will posit to you that your state, this country, and you as individuals cannot afford to see this curve continue in this direction. And how do we do this? Well, we pay more out of pocket, we pay more in premiums to get this, or we simply do without. And you might as well not even have the drug if you can't afford it. So imagine in this great country where we have to forego therapy because why? We can't afford the medication. Value-based healthcare, again, this is where we're paying for value and not just fee for service. And here are some of the areas where we're looking at this. Maximizing health IT. Now, this isn't just an electronic medical record, which is what your doctors do. The last time you went to the doctor's office, did you see his or her face? Or were they focused on a screen and typing in things? That's what you're seeing more because of the burden of IT. And the other thing that we're trying to emphasize is interoperability. So, for example, if you were to go to Intermountain Healthcare in Salt Lake City, 5 miles away from St. Mark's other trauma center, you couldn't get those records from St. Mark's Intermountain or vice versa because they're different healthcare systems. And that's the same way it is in each and every one of your states and towns. We don't have that interoperability, which leads to duplication, redundancy, costs, and frankly, harm. Pioneering bold new ideas in Medicare and Medicaid, and also removing government burdens with decreasing duplicative regulations, and also adapting the new STAR clause and kickback clause. So, for example, it used to be that you couldn't refer a patient, say, for example, in your own practice to someone within the same practice because that would be in violation of the STAR clause. But in terms of coordination of care, sometimes that is absolutely what you need to do so you don't have to have problems with information transfer and continuity of care. Now, this is where we're going to talk about, and you have some experts, so I'll talk about this briefly, and then I'm going to let the experts take over on this. But we know that today, for example, there was the rollout of more available short-term limited duration health insurance. These are new innovative plans that go from the previous 3 months under the Obama administration to now 12 months, and they are now renewable up to 36 months. Now, they have a different variety in terms of the coverages, but the cost is estimated to be 50 to 80% less than the traditional ACA compliant insurance. So you say, well, what about this? Is this junk insurance? Well, let me just tell you. My wife is a realtor, and her association does not provide health insurance. And so that's a big problem. And if you've gone into the individual marketplace, right, and you've looked at the health plans, high deductibles, several thousands of dollars, high out-of-pocket costs if you were to even able to get that health insurance. So that was one problem. My son recently graduated from college, and before he could get into a health plan, he had aged out of our health insurance. He was left without health insurance. Can you imagine if he had had an appendicitis or an acute auto accident this time? So he went out onto the marketplace, $600 to $800 per month for a healthy young man to get health insurance, just so he could have an ACA compliant, because that's what's all there was. And at the time, there was also this big penalty that if you didn't have health insurance, you would get to pay a penalty. And Americans paid billions of dollars in terms of penalties just so they couldn't have health insurance. So that was an irony, and that has been changed. So one other interesting change, and this affects me personally, but it will also affect those of you who are physicians and those of you, for example, Sarah Henderson's sister is a nurse practitioner. The E&M codes, which have been the drivers behind reimbursement for Medicare, right? And most of us use those. They've been simplified from these really onerous, huge documents, such that once you document certain things like a family history, social history, granted, all important, but you need to document that same static fact 20 times through a patient's chart. Well, you have to under this current E&M. So that E&M has changed. That's going to decrease by hundreds of hours for doctors every year, and they will give them more time with you face to face rather than working on a screen. Now, they're also going to, and this is why you need to comment, there is a public comment period now where they're going to standardize the E&M reimbursement from rather 5 different levels to 2 different levels. And also for the family docs versus the specialists, there are modifiers so that there should be no net change in terms of the overall reimbursement, which was very reassuring to me when I talked to my oncology colleagues. Well, you guys, you're going to hear some great experts. I look forward to learning from them. We know, for example, they'll talk about the 1332 waivers, the reinsurance issues that just came out that will help you in each of your states in terms of your high-risk pools to lower costs, to increase competition, and to decrease premiums and make this more competitive. So I look forward to listening to them. I listen to hearing more about the short-term duration, their take on that, and also on association health plans and other topics like that. So thank you for letting me share a few minutes with you today. It's great to be up here, but I got to tell you, it was wonderful to sit in the audience with you and to be a partner with you at that time as well. So thank you very much.
Well, I'm going to go ahead and start. Dick will get my stuff up, but usually I start my speeches by asking who here knows their insurance commissioner, but your state legislators, you guys know who they are. I encourage you, because what I'm about to talk about is really more broadly over 50 states, D.C., and territories. If you want to really know what's going on in your state with regard to rates and plans and things like that, you can talk to your insurance commissioner's office, talk about what's going on. I know your constituents are coming to you. There are grave concerns. The affordability of coverage, the affordability of care is still a major issue for millions of Americans, and we need to keep working on that problem. So I'm going to start today by really looking at where are we at right now. As we look to 2019, which will be the 6th year of the ACA market reforms, where are we in these various markets? And we'll start with the individual market. That's the one that, while it's the smallest of all the markets, it's the one that gets all the attention, and for right reasons. You have to remember, individual market is different because people are paying 100% of the freight. They're not getting subsidized by their employer or other sources, and they may get some federal government grants or tax credits, but most of the people are paying their own way, and that's why it is so volatile. And we're going to look at, first of all, rates. Overall, what we're seeing as rates are coming out, and by the way, we have checked, and if you go to ratereview.healthcare.gov, all the rates are up today. All the initial rates that were proposed by the companies are up there. You can take a look at them, see where they're starting. I would note that is just the starting point. Your departments of insurance will be reviewing those rates. In a few cases, the feds will. And they'll be looking at those rates and come to final rates later this summer or early spring. Early fall. What month is this? Those early flights will kill you. But overall, what we're seeing is much better than last year. Frankly, Maryland came out first. Anybody from Maryland? Maryland came out, and everybody panicked. Your guys came out very high. Your initial rates were very high. And everybody said, okay, here we go again. We're going to have the 50, 60, 70% increases again. It's going to be a terrible year. It's all that individual mandate penalties fault. It's all so-and-so's fault. And then Virginia came in. And everybody went, whew. That's not so bad. And since then, we've had some states actually come in with negative numbers. And I'm not just talking about the reinsurance states. There are other states without reinsurance that are coming in with some negative numbers, some flat numbers, 2 or 3%. Most of them are going to be in your high single digits, 7, 8, 9, to low double digits. And everybody's saying, okay, that's better. That's the overall picture. Now, we can take a little sigh of relief and say it's not so bad, but it's kind of like sitting there saying, well, we're only supposed to get 6 inches of snow today when you have 6 feet of snow outside. How you feeling? 6 inches is better, but when you still have 6 feet of snow, you still got a problem, don't you? And that's the problem. When we look at the rates, especially for the unsubsidized population, because the subsidized population is insulated from those increases, but when you look at the unsubsidized population, even if it goes up, let's say 5, 6, 7%, you say, okay, that's still completely unaffordable for most of your subsidized population. And that's where the problem will continue to be. That's where states need to continue to work with the federal government, or if the federal government's not going to do it, work at the state level to try to figure out through different things that Justin's going to talk about, like reinsurance, 1332 waivers and things like that. How can we get those rates down? Because we have to start making it more affordable, especially for the unsubsidized population. Otherwise, they're going to go someplace else. And that's what we'll look at in a minute. We also have out-of-pocket costs. Those continue to go up. So even as rates continue to go up, or even if they're moderated, even if they're going down a little bit, they're still too high, and people are looking at it and saying, I have a very high deductible, very high copays, why am I paying all this money? That question is going to be in the minds of many people again in 2019. The availability is better. Last year at this time, we were saying there could be some bare counties in Arizona, in Tennessee, maybe some other places. We were looking around the map and saying a lot of states only had one carrier in a lot of the area of the states. Much better this year. We have some carriers, in particular some of the Medicaid managed care companies, some of the hospital-based insurance companies that are starting to come in. We're adding carriers to the market. Nobody had to worry about bare counties. At least no contracts have been signed yet, so we never know what the next few months. But well, so far it looks good as far as availability. There's also the question of options, though. We're still looking towards a trend of very few options for consumers. Few carriers, but also those carriers are pretty much offering narrow networks, HMOs. You don't really have the broader network options that we used to have. So that's something we're also looking at. Now let's look at the small group market just briefly. It has been more stable. The rates have been actually going up fairly consistently, not nearly as high as the individual market. There's still some concern there, though. There's still some concern there about, again, the affordability, especially if you're a small employer and try to make that affordable for you and your employees. We're still going to have to look at that. The stability is better. We don't have carriers really coming in and out. So it's better, but we still need some work there. And large group, it's okay. It's rolling along. They have a lot of leverage. Really, that's where we see stability, and that's where we see the carriers and the companies really looking at ways to improve the marketplace, address cost, wellness programs, through payment systems, those kinds of things, really trying to address some of the cost issues, and we need to keep encouraging that. So let's get to what are the challenges. So first of all, impact of alternative plans. Now that we have, in the second bullet there, you see the individual mandate penalty going away, at least for a time. We'll see how long. As that penalty goes away, it really does open up options to people, especially some options that maybe they wouldn't think of before because they get the penalty. That's that fourth bullet there, the other plans. For example, we're going to talk about a little bit of Iowa, Tennessee. They have a Farm Bureau plan. It's not insurance. How do we know it's not insurance? Because the legislature said it's not insurance. So, but now before, if you took that insurance, you have to pay the individual mandate penalty. Now you don't have to pay the penalty, so more people are going to go for that. Something outside the ACA market. Are more people going to go for the sharing ministries? Which again, state legislatures say these can be sold, they're not insurance. Will people go for those? Will people go more for limited benefit plans or package limited benefit plans? Without the individual mandate penalty, the question is, will people start going for some of these other plans outside the insurance market? And then what does that do to your insurance market? Are we going to go back to where carriers are pulling out again? Rates are going up faster again. What's going to happen? We have the short-term limited duration plans, as was mentioned by the doctor. We'll see what the impact there is going to be. What kinds of plans are going to be offered by what companies under what conditions? Let me ask you something right now. Raise of hands. Who here regulates short-term limited duration plans? Everybody raise your hand, quick. States do. States regulate short-term limited duration plans. So it's going to be up to you to decide how you're going to regulate these. If you see a problem, you're going to have to address it. Association health plans. Let's just try this again. Who here regulates association health plans? Everybody raise your hand. States regulate association health plans. It doesn't matter if they're fully insured, buying insurance, or whether it's self-insured. Either way, under ERISA, under the Early Born Amendment, states regulate association health plans. Even these new ones. They are MEWAs, multiple employer welfare arrangements. You regulate them. So again, you're going to have to decide how you're going to deal with these plans. what impact they're going to have, how you're going to regulate them, and then transition plans. Again, that was up to the states whether you wanted to allow these transition plans to continue. And right now, the federal government's going to allow them through 2019. Whether they're going to allow it past that, I don't know. Do you know? Oh, no, we don't know. But you have to, again, decide what's the impact going to be. Then we have lawsuits. Lawsuits has been one of those interesting things with the ACA. We've had lawsuit issues from the very beginning, always bringing in a level of uncertainty. We have the risk adjustment. That was in the news. Down in New Mexico, one insurance company, a co-op, said, I'm going to challenge that formula because I don't like it. They challenged it on one point, which was the statewide average, using a statewide average to determine. The court said, we're not very comfortable with that. We're going to remand that back to the feds. You guys justify it. Well, in an interim final rule, they just did. So they justify it, so payments are going to go out. They're going to do a notice of benefit payment parameters. They're going to do basically a proposed rulemaking for 2018. 2019 they've got covered, so we'll see what the courts end up doing in the end there. Texas case, that is where 20 states are challenging the constitutionality of the ACA once again, because once you take away the individual mandate penalty, it no longer becomes a tax issue. This is their argument. When you take away the individual mandate penalty, therefore it's no longer a tax, therefore those requirements like guarantee issue, pre-existing condition exclusions, prohibition, rating rules, all those things should go away. That is their argument. We've got 17 states on the other side who are saying, no, we're going to defend this because the federal government said they're not going to. We'll have to see how that turns out. And just add one, we have now 12 states challenging the association health plan rule. And how many want to guess if we're going to have somebody challenge the short-term limited duration? I don't know. But it seems to be what we do nowadays. So all these are going to create some challenges moving forward. But the bottom line, here's the bottom line, folks. You got to figure out how to help the unsubsidized population. You have the ACA, you've got the federal subsidies, you've got the rules. If you're sick, if you're poor, you have someplace to go. You have coverage you can get. The question is, what about everybody else? Can you figure out how to help the unsubsidized get more affordable coverage without damaging what's been set up for the, what we'll call the sick and subsidized population? How can you do that? And that's going to be the challenge. And Justin's going to talk about some ways and ways to think about that.
Thank you, Brian. And thanks, everyone, for having us here. Picking up on where Brian left off, I'm going to talk for the next few minutes about specific options that states have to address that affordability issue, really focusing on this individual health insurance market. As Brian indicated, it's the smallest market, but it is the one that, for a lot of good reasons, we pay a lot of attention to, and it's the one I'm going to pay a lot of attention to over the next few minutes. I cannot help myself, perhaps because of my previous career as a lawyer. I've given you a whole bunch of text-heavy slides, which I don't think I'm going to get to everything on them, but I'll flag, hopefully, some of the important things to think about. So I'll lead off with, we were saying at the beginning of this, all of us together here, that the big news on Sunday, Monday, was related to reinsurance, and we'll get into why that was here in a second. It's now Wednesday, and that is a lifetime these days, and so we have other big news. But I'm still going to lead with reinsurance, and that's because it seems to be a solution that has relatively broad appeal at this point as a potential option for states to help moderate premium rates in their states. So in general, what is a reinsurance program, right? It can design it in a number of slightly different ways that can be important, but basically it helps blunt the cost of high-cost enrollees. And we've had success with it on a federal level. There was a temporary reinsurance program in federal law, and it accounted for double-digit premium decreases in the first year of the program. And we know that states that have done this have seen good success with lower premiums. There aren't federal dollars for this anymore. There was a bipartisan bill that would have supplied federal dollars, but it did not pass, and it's not likely, I think, to pass anytime soon. So it's on all of you, and that's going to be really a theme for everything I'm going to talk about. It's an option if you see value there, and there, of course, are some important hitches and things to think about, which we'll chat about in a second. But this is an option that, if you want to pursue it, states have to take the lead in doing so. So how do we tend to go about these reinsurance programs these days? The key hook, right, are these ACA innovation waivers, because they combine state funding. That's something that you all will have to come up with, and that, of course, might be hitch number one to these types of programs. You do need state funding. But the waivers allow you to access federal pass-through funding. And we've seen from the applications, the waivers that have been granted so far, and the ones that seem to be on the way to being granted, that the feds are picking up most of the tab for these programs, about just under 2/3 of the cost of these programs, and you see a range of what we see in terms of premium decreases because of the programs. Depends on how much money you put into the program. That has obviously a big effect on what the decreases look like. But we're seeing substantial positive effects on rates because of these programs. So in terms of the waivers that you need for reinsurance, and you can think about more broadly, I'm sure many of you are fairly familiar with these, and there are many considerations that go into them. I'll just hit a couple of high notes, as it were. So, of course, this is a program that allows a state to waive specific provisions of the ACA so long as certain procedural and substantive requirements are met. Those procedural requirements are designed, at least in theory, to ensure broad input on the waiver design and stakeholder involvement. They're designed to ensure that a lot of the analysis that has to go into these waivers occurs and then can be evaluated by the feds, which is all to say is that the procedural requirements are lengthy, and there have been some criticisms about exactly how lengthy they are, but the bottom line is they are what they are right now, and so planning for all of these things really needs to start early if you're thinking about waivers. There are the substantive requirements which are in statute and have to be abided by, and they, broadly speaking, try to ensure that a world with your waiver leaves folks no worse off than they would have been without the waiver, no worse off in terms of cost, in terms of having coverage at all, in terms of the type of benefits that they would get through their cost or through their coverage. And these waivers have to be deficit neutral to the feds. And so a lot of considerations to think through here, as you probably know. But two threshold things that I would highlight here and do at the top of the slide is that states thinking about this have to have legislation. So you all, many of you, the states out there, you've thought about this and you have a law to authorize a waiver submission. If you don't have one and you want to pursue this, you need to pass a law. And so that really, if not step number one, it's certainly a prerequisite to everything that follows. And number two, it depends on your waiver, what waiver you're trying to get, but certainly for something like reinsurance, you do need state dollars. You can design a program in different ways, so you may need comparatively fewer state dollars, but you need state dollars, and that obviously is a hurdle in many places. So what kind of waivers do we have? Just hitting really quickly on what we've seen so far, reinsurance really has been the most popular type of waiver and really has enjoyed support from states, regardless of the political persuasion of the governor's house and the legislatures. We've seen 3 states with reinsurance programs in place for this year, and we were just joined, this would have been the big news come Sunday or Monday, by 2 additional states that received approval from the federal government. Wisconsin and Maine will be operating partially federally funded reinsurance programs in 2019. We've got 2 other states in the pipeline, Maryland and New Jersey. I'd anticipate that those applications would be approved, and I would imagine, and maybe we can talk about this more later, that there will be more states strongly considering this in future years. Aside from reinsurance, I would say it's early yet in this program, although I feel like we perennially talk about it situations like these. The program is only about 1.5 years old, and so we have not seen some of the big picture waiver proposal that some folks have sometimes thought about and talked about from again, all sides of the political spectrum here. But those remain a possibility, and certainly as we gain more experience with how these work, it's really worth thinking what all can be done with this waiver. Something slightly more narrow bore that we are starting to see, and I highlight quick, is what we've seen in Rhode Island. Rhode Island recently passed two laws, one to get the ball rolling on reinsurance, but another to allow or to authorize the submission of one of these waivers to allow folks who are sole proprietors and are finding costs to be really tough in the individual market, to allow them to buy through the small group market. Now, a couple other states have thought seriously about this proposal as well. They've looked at it in a couple of different ways that may have some legal issues that you bump into. But pursuing this by waiver, there is, I think, probably more clean from a legal perspective, and it is a potential avenue talking about and thinking about affordability for folks who are unsubsidized. This is an avenue to think about, allowing folks who are likely not getting subsidies in the individual market to have another option in the small group market. So moving a little bit to a different issue, but now the topic of the day, short-term health plans. So everyone so far has talked a little bit about this, and I would add a quick overarching note and then some things that you all can think about. So again, the idea with these plans is that they were intended to be gap fillers. They last a shorter period of time than do traditional regular insurance, and the idea is where there are benefits and there are risks, depending on how you look at them, comes from the fact that they are really separate from traditional health insurance. It's a different risk pool. They don't play by the same rules. They are not obligated to follow the same requirements, if you will, as all the other health insurance that we've been talking about. So as a consequence, if you're healthy, you haven't been unhealthy, then you're going to find potentially a cheap premium, a cheap upfront cost. If you're not healthy, if you do have a pre-existing condition, and these are potentially a much more difficult to obtain option for you, and perhaps difficult to afford if you are offered that coverage. And so that's the trade-off. So they do provide affordability at the front end for some folks, potentially not for others. So a number of things to think about as you think about how you all might regulate these. The first is to embrace this federal framework that we've seen finalized today, and allow these plans to proliferate in your state, and again have the option for folks who are healthy to access this sort of cheap, skinnier coverage. To some extent, the other extreme is and a few states do this currently, you can require these plans to play by the same rules as other health insurance. The effect of that tends to be to dry up the market for short-term coverage in those states. Now, in between perhaps those poles, there are a number of other options. We've had a lot of talk about limiting the length of time that these short-term plans can last. So now they're allowed to go for 364 days under the federal framework. Well, states can lower that bar to 6 months, to 3 months. Several states have done this. We would anticipate that more will do so. And I would say, just as you think about that as a potential option, it's really worth thinking about issues of renewal and issues of where an insurance company issues a consecutive policy to a consumer. So and decide where you want to come down on the spectrum, because one thing that you can have is a law that says these plans can only last 3 months, but then someone can renew for longer. You can also have a situation where a person can keep getting these policies, a new policy over and over again. So depending on what you're trying to accomplish, there are a lot of ways to change the length of time they may last, and that can have effect on your broader market and on the availability, of these plans for your residents. So moving quickly through some of these other issues here, we talked a little bit about association health plans. Broadly speaking, they raise some of the promise and concern as short-term plans do. With one additional thing I would add, one issue with these health plans, they offer potentially some promise, but they have a long history, as many of you may have experienced, of leading to fraud and abuse, where they've gone belly up and left consumers and your residents on the hook for unpaid claims. And so to the extent that these do get larger in your states, they become a broader option. One thing to think seriously about is making sure that your agencies have the tools in place to look at them and to make sure that they're following state law, that they are not taking advantage of residents, because of course many of these associations don't, but certainly many of them have over time, and so that's really a key issue. So my time, predictably, is nearly up, so I'm going to just highlight a couple of more quick things. So on the next slide here, we look at a couple of states that, as Brian alluded to, have, in a real effort to try to improve affordability on the front end for folks with lower premiums anyway, have come up with ways potentially to get around of the federal health care consumer protections. The situation in Idaho, I think, is still sort of open, and we have Iowa, we have Tennessee that have gone this route of carving out plans from the whole definition of health insurance. And so there are potentially positives in that you've got a plan that might be cheaper, but you also have a plan that is effectively not regulated at this point, and obviously there are some potential dangers there. So as with everything, of course, there are trade-offs. This stuff is not easy. The two other things that, in talking about affordability, we talk a lot about premiums, and rightfully so, but there are other aspects of affordability and other ways to address them. And so we've seen several states kind of go a more direct route in some respects and provide financial subsidies directly to consumers. This is, of course, what the ACA does, but states have the power, if you can come up with the dollars, that of course being a huge limitation, I know, to providing additional subsidies and perhaps directly to the folks who are not subsidized now. That's a carrot. The stick is the individual mandate that goes away at the federal level, and I know many of you might be very pleased about that come 2019, but other states and other policymakers in some states have sought ways to bring a state mandate in, and really one of the potential benefits of going that route, if you're so inclined in the first place, is you have the flexibility now to design it. So you can figure out what the right balance is for that kind of requirement. And so, for example, New Jersey is going to have a mandate in 2019 for better or for worse, but one thing they're doing is using the money they raise from the mandate to pay for reinsurance, and so to help their residents in other ways. Last, really quickly, on the Texas case, that lawsuit that Brian mentioned, where there is this other challenge to the Affordable Care Act, I would just say that, again, what's ultimately at issue in that lawsuit are these pre-existing condition protections in federal law. Whatever the pluses and minuses of the rest of the law seem to have polled consistently popular among the public, and these, depending on how the lawsuit comes down, are in jeopardy. And so some states have those pre-existing condition protections for folks in state law. Most states don't. It's certainly something within your authority, obviously, to think about building those into state law to provide those sorts of protections in case they go away at the federal level. Thank you so much, and looking forward to chatting in a few minutes.
Thank you, Justin. And I will wait for Dick to do. I'll quickly get into my slides too, so that we can leave open time for questions and answers as the new slides come up. Thank you for having me. My name is Leanne Gassaway. I'm with America's Health Insurance Plans, and I'm hoping that you have the slides in front of you as well, which outline AHIP's vision there in case you don't know who we are and what we stand for. We try to shape the market to improve health affordability and financial security for the customers that we serve. So one thing I want to talk about, and both Brian and Justin have mentioned it, is what are the markets that we're talking about? Because we seem to say that the health insurance market is broken. And I think that it comes with a little bit of a misnomer about what market. And so I always like to start with this slide because it really shows you where folks live within their health insurance needs. And as you can see, the vast majority of people live in the employer-sponsored market. About 155 plus million people get their coverage through their employer today and have some kind of post-tax or pre-tax benefit to that. and also enjoy an employer subsidy usually of some kind. And so that market has been relatively stable, anywhere between 90 to 95, even up to 99% of employers, depending on how big of an employer you are offering coverage. And so that market is very stable, it's very competitive, and it has a lot of innovation going on in it. And then when we look at our public programs, Medicare, TRICARE, CHIP, Medicaid, very large programs, getting larger. Medicare is getting bigger as we're all aging. And as baby boomers come into the Medicare program, that program will blow up in terms of who it will be covering. Medicaid obviously has expanded under the Affordable Care Act and continues to get bigger as states debate how to expand and offer more affordable coverage to low-income adults and families. And so those markets are primarily working as well, although any state legislator sitting here in the room saying Medicaid is causing my budget a pretty penny and we need to address costs, but that's not usually what we're talking about. We're talking about the health insurance marketplace. It's that orange box in the middle that we have been talking about for 8 years. And so it's 18 million folks. It's a market that didn't work very well prior to the Affordable Care Act and continues to have challenges, as Brian and Justin have talked about, in terms of how it serves customers who have to buy insurance on their own because they're either self-employed or they don't get insurance through their employer or they've retired early or whatever the case may be. They're in that individual market, and that's the market that we continue to work on the most. A lot of folks also ask me, why are we talking about rates in August? I mean, these policies aren't going to be available till January, so why are you guys all flustered about rates in August? And I just wanted to leave you with a timeline of how the product cycle works between us and our regulators, who have to review those rates to ensure that they're adequate, they're non-discriminatory, and that they're effective and not unreasonable, so that we can offer them the consumers that we serve. And so this timeline begins all the way back in November when my companies begin to start developing those products that they're going to offer a year from then. And then they have to file them with the regulator, as you can see. Most of them start filing between April, May, June. Give them to the regulator, have them actuarially reviewed, make sure that everything's, the boxes are all checked, everything's where it should be, the numbers are lined up, the trends all make sense, and then the regulator has to approve those rates. We have to load those rates into the individual market apparatus, if it will be, so that folks can start open enrollment just like you do as an employer. If you think about your employer-sponsored coverage, usually around October, November, you get a fund packet from your employer that says, here, pick your plan. The same thing happens in the individual market today, where we go in about October 15th, we open up enrollment and send those folks a packet and say, pick your plan. And so that's why we are talking about rates here in August, because we had to file those rates about 2 months ago. Those products are now being reviewed by your regulators in the state, and once those are approved, they will be loaded into the system to become available on October 15th for folks to start to enroll in for a January 1 effective date. So I just wanted to get those dates out there because I think a lot of folks don't understand how the product cycle always works and why disruption and uncertainty in that product cycle can affect market participation. It can affect premiums. And last year in particular, we had a lot of uncertainty going on through the summer, where we had a lot of plans who had filed rates in April and May, and then some changes happened in the middle of the year, particularly related to cost sharing reduction benefits, and plans had to refile everything in late fall, trying to make that October 15th date. So the more certain that we can make this environment, and that's why I think we're seeing what Brian talked about, a little bit more stability, a little bit more availability, a little bit more predictability in rates, because we know what the rules are this year. Now, the short-term rule this morning, we knew it was coming. It wasn't an aha moment. We know exactly what it was going to look like, but our companies had already incorporated that in the rates that they had filed back in the summer. So we have a little bit more of what the rules of the road are, and that's why we're seeing some stability in the marketplace. However, this is all happening around us. That creates a lot of challenges, uncertainty, and a lot of questions about where are we going as a healthcare system. And this is what we are working on every single day at AHIP in your communities, with your legislators, with your regulators, to talk about things like affordability of care, particularly for the population that Brian identified, which is the unsubsidized population. Because about 80 to 90%, depending on which state you're sitting in, 80 to 90% of those buying coverage in the exchange, in the individual market, are getting a subsidy. So those premium increases largely don't impact them because the federal government is picking up the tab. Their costs are capped, if you will, at a certain number according to their income. But your unsubsidized population, your middle-class families who are paying the full premium, are feeling that affordability hit as those premiums go up every year. So we are working every day to try to come up with new innovative ways to address that population in particular. We have access issues. We want to ensure that we have proper access. But having broad networks or being able to go to any doctor or any hospital today is just not a cost-effective manner of giving health care to folks the way that we contract with our providers. Provider consolidation is having an impact on rates. U.S. unit prices, you hear a lot about, as Dr. Shinazawa said, we have other unit costs that are going up. And we pay more in the U.S. on a unit basis than anybody else in the world. And so we are trying to bring down those unit costs in any way and manner that we can, because that's going to lower premiums and make costs more affordable for consumers. We have entitlement spending and budgets, and you guys know firsthand when you have to do your budgets at the state level, they have to be balanced, and your Medicaid budget is squeezing more and more and more out of your state budget every year. And we want to ensure that those Medicaid programs are running efficiently so that you don't have to be cutting K through 12 education, you don't have to be covering law enforcement and prisons by diverting all those funds into your Medicaid program. We want to make and partner with you to make those programs work efficiently. And then all this stuff in the middle about how do we move forward. And are we going to talk about single pay? Are we going to talk about buying into the public program apparatus? How do we stabilize the market? What are we going to do about drug prices? How do we expand Medicaid? Or is it even feasible in my state? And so these are all the discussions that we're also having, and they're all connected. And so we have to approach this in a holistic way because just pushing on one of those is kind of like a game of whack-a-mole. You know, if you push on one of those, it's going to pop up somewhere else. And so we have to be holistic as we look at this. So when we look at factors that are affecting premiums, this is how we look at how do we press on these levers to make the products more affordable for the consumers that we serve. And there's 5 basic buckets that affect the cost of a premium. Prescription drug prices today, and I'll talk about this a little bit more in my next slide when I talk about the healthcare dollar, but this is having a major impact on the consumers that we serve. Who is covered? And I know this is a very wonky thing, but if you think about, you know, you have 100 people and 50 of them are sick, but 100 people carry that load. That creates a price of $100 for everybody. But if 20 people out of that pool decide to not buy, and now you've got 80 people, but 50 people are still sick, that cost is the same, but it's being shared by a smaller number of people. That's when we talk about risk pools, and we talk about how do we improve the risk pool. How do we get more people in there so that we're not going down, we're actually going up. Because if we go up and we now have 50 sick people, but we have 500 people paying that, they're all paying a little bit less. So that's what makes a big difference about who is covered and what we've seen in the individual market in particular as these other products come online and why that's impacting premium rates. Because as more healthy people potentially leave the market to go buy a short-term plan, an association plan, a healthcare sharing ministry, or something else, they're taking those dollars away from those who have pre-existing conditions who need that money paid for. So who is covered is vitally important. Which care providers are participating in your network? And that's what we talked about when Brian talked about narrow networks versus broad networks. How those networks are configured and what kind of discounts you can make and partnerships you can make with your provider community is going to greatly affect how much you're paying for those unit prices and how much you're paying for care, and that's going to affect the premium price. Value-based models hold so much promise. This is something that our companies are just, this is where the innovation is happening, particularly in the large group market, where you can go to a health system and say, I want to partner with you and pay you a completely different way than we've paid you in the past. We want to share savings with you. We want to do this with you, and we want to share risk with you. And this is where we are going to achieve savings together between health insurance providers and healthcare providers. So, and then the last is taxes and fees, because, you know, we got to pay taxes and fees, and the more that those go up, the more that it adds to the premium. The health insurance tax is when just glaring part of that. And I want to talk about the healthcare dollar really quickly because this is how the money is spent. And this is the second year of which we've produced our healthcare dollar. We did one in 2014, the first year of the ACA, and we just reproduced this showing a 3-year rolling difference. And I want to just make it clear that this is where the healthcare dollars are being spent. So this is about unit prices and utilization. And right now we are spending more on prescription drug pricing than any other category of medical care. 23% of the healthcare dollars going to drugs, and that's not including inpatient drugs, because the inpatient drugs are in that inpatient box with the hospitals. So this is just retail and physician-administered drugs are 23% of the healthcare dollar today. Physicians is the next block at 22%. Then we have our hospitals. Then we have our outpatient care. And then we've got the administrative services on the end there. And so what we want to make sure that everybody understands is how those healthcare dollars are being spent, and they're being spent in a very responsible way, the best way that we know how to serve the consumers that we serve. So this is just this is brand new data that we just released about 4 months ago, so we just wanted to make sure you had that with us, and happy to take any questions.
Great. Thanks to all of our panelists. Thank you, Leanne. This is now your turn to ask some questions and drive the conversation. We specifically want to make sure folks have the chance to ask Dr. Shiozawa, take advantage of the fact that you have a HHS representative here if you have questions on administrative actions. There's microphones right down here, and please let us know who you are. Maybe we have our first question. Please.
One of the large insurance companies that represent our managed care population is proposing a dual eligible, what's my term? Advantage. How would that work? I've just heard it. I've never seen it described to me. But have you heard anything about a model that would take dual eligibles and create an advantage plan out of that?
Yes. So this is what many of our companies are committed to right now. Many of our companies participate in Medicare and they participate in Medicaid. And so you have a lot of low-income seniors or disabled seniors who are eligible for both programs. And it creates a big kind of mess when they're in both programs. So we have our companies who are working directly with CMS to put those programs together in one coordinated program called Dual Eligible Partnership Program. And they're launching these in certain states on a pilot basis to coordinate all the Medicaid services and all the Medicare services together in one.
Do you have any material that you could send me that describes exactly what they're doing and how it works?
I can. Yes, and if I can get your card afterward, I can get that to you.
Great, thank you. Next question.
Yeah, I'm Dr. Dave Weldon, a former member of Congress. Now I represent the Alliance of Healthcare Sharing Ministries, and I have a question for you, Leanne. Though I represent these ministries, I actually have Blue Cross Blue Shield. And so one of your last slides, the dollar bill stretched out. I just want to make sure I'm understanding your numbers correctly. So I send them $100 or $1, let's say, and what you're saying is 0.7 cents is for the administrative costs to Blue Cross Blue Shield, and 2.3 cents is profits to the corporation?
No, actually about 16% is full administrative costs. But what we did is we took those administrative costs and broke them out by the categories of how the administrative costs are being spent. Are they being spent in care coordination, clinical management, fraud and abuse detection, pure administration, and then profit? So that's what you see on the bottom there, are the administrative costs broken up.
That's what I thought. And is that an aggregate across, an average across all the different insurance companies that are part of your association?
Yes, so this is aggregated data that we wanted to show a complete picture on a national basis of how that was derived. And so we worked with Milliman on this.
Okay, thank you very much.
Sure.
Hi, my name is Wendy Chill. I'm with the American Academy of Pediatrics. I had a question regarding state regulation of AHPs, and maybe this is directed at Mr. Webb, because I saw some reports that NAIC was having regular calls with the Department of Labor for clarification on some of the points regarding state regulation of AHPs. So I was wondering if you could talk a little bit about what specific areas NAIC was concerned about, and what, if any, responses you've gotten from Department of Labor on that.
No, as was mentioned, one of the big ones is the potential for fraud. Also, just the potential, we have a lot of problems, not just with fraud. Some were very well intended, but just incompetent, unable to run an insurance company. So that's where a lot of the conversation is. How can we work together with the federal government? In order to have these, you have to fill out a form called an M1. Are we collecting all the information we need? Are the states getting the information they need? Are the federal government getting the information they need? Because they have cease and desist authority. States can also take authority over them. So it's just coordination, conversation, communication. We have memorandums of understanding with them and those kinds of things. That's where the main conversation is right now.
Okay. Because my understanding is that there is some confusion in terms of exactly how far states can go in regulating AHPs based on some of the language that was in the final rule.
There's no confusion on our part.
Okay.
Yeah, at all. I would just jump in to really agree with Brian. I mean, I think there had been some confusion certainly based on the initial proposal, and not to get over technical, there's certainly some federal authority that lies underneath a lot of this stuff. But the finalized rule was very clear in many places that the feds are going to be relying on the states. The states retain broad authority in this area. And so really, if it's something that you're thinking about regulating in, you should continue to think hard about what works for you.
Thank you.
Good afternoon. Thank you for your wonderful presentations. I'm Karen Lewis Young, and I'm a delegate from Maryland. We have experienced an increased level of conversation about single payer, and not just legislators, also constituents. Last night I had a town hall, a telephone town hall with 2,000 constituents, and this issue was raised as much as, why are my prescription drugs going up? They're looking at other models around the world, seeing better outcomes, much lower expenses. So my question is, how feasible is it at a state level? I've seen numbers thrown around about the costs, but I'm not seeing numbers about how much could be saved. And I wondered if you're aware of any states that have done a pretty in-depth analysis, or any organizations that have started to build financial models.
Great question. So 2 states have probably traveled down this pathway the most, and that's Vermont and California. So Vermont, several years ago, tried to develop a comprehensive single-payer program and got to the final and had done some financial analysis. And the governor, who was actually the biggest proponent behind it, had to abandon it because it would financially have bankrupted the state. I'm a little more familiar with the California single-payer initiative. That was that's SB 562 or AB 562, and that bill would have cost the state about $400 billion a year, which is double the entire state budget of California today. So it would, and they did an extensive analysis, and they have a huge report. I think it's even online that you can get it from the California Legislative website, where they went through in detailed manner about where those costs come from, and what the savings. And there was a group, the proponent group, did their own analysis and still came up with about $320 billion, so it was less, but still significant. And I think this is the biggest hurdle, is that we aren't talking about affordability when we're talking about single payer. We're really just talking about access, right? How do we improve access for everybody so that everybody has access to care? And so I think we have to have a good, robust discussion about how do we move from abandoning the coverage that 155 million people have through their employer today, or the 55 million people on Medicare who are going to lose that coverage because you want to put them into a different system, because 18 million people are unhappy with their premium increases. So I think that's the discussion that we have to have a little bit. It's not a nice conversation. It's tough. That's why we are really working right now on how do we get innovative around using some of the waivers and other stuff. So for example, I don't know if Idaho state-based plans was on your slide, but Idaho actually tried to do an 1115, which is a Medicaid waiver, coupled with a 1332 state innovation waiver, of which they identified 7 medical conditions, 7, that accounted for a tremendous amount of prescription drug spending, and figured that if they could move those individuals with those 7 conditions into their Medicaid program, they could lower individual premiums in the market 20%. 7 conditions. Now that is innovation, right? That's the way to how do we go about addressing affordability in a much more robust way. And so I think that's the conversation we're looking to have in our states with you guys and gals on how do we bring down the costs long term, because it is unsustainable where we are today.
Thank you.
Go ahead, Justin.
If I could just jump in really quickly with 2 points on this. I think, Leanna is quite right. When you talk about that issue, you're talking about significant costs that need significant deep analysis, which we don't necessarily have in a lot of places yet. And hopefully it does continue to get studied. I mean, I throw another state out there. A couple of years ago, there was a ballot initiative in Colorado, which was soundly rejected to go down that path. But that may be another area to look for some additional analysis. But I would say also, when people talk about single payer, sometimes it's not clear about what the ultimate objective is, and to the extent that it's universal coverage or whether it's single payer, and they don't necessarily have to look the same in the details, and that can be pretty important. And so it's just, as we continue to think about all this, it's important to drill down on that. And then last but not least, starting to get a little bit out of my zone here, but on Idaho, there was an excellent point that there was a lot of good thinking going on there to deal with some of the realities in the state. But it's interesting, by the state's own analysis, and those proposals, had the state expanded Medicaid, they would have saved the state more money than in the joint proposal that they had come up with. So it's great that we're continuing to evaluate and think about this stuff, but there are a range of options already available.
I'm John Dick from the Wisconsin Legislative Fiscal Bureau, and I want to follow up on the AHP regulation and what states can do. And you talked about states being able to regulate. I assume you're talking about fully insured plans. What potential is there for states to get benefit mandates or the whole range for self-insured AHPs? And does ERISA prevent states from doing that? Or?
No, actually, ERISA specifically gives states authority over self. In fact, it's actually clearer that states have authority over self-funded association health plans than under fully insured. There's some tiny questions we have on fully insured, but self-insured, it's very clear. They can really do anything they want. So,
I apologize for the second time, but there's one issue that really concerns me, and that is drug costs being the highest percentage of the medical dollar. What can we do to have more transparency with PBMs and how they're the ones that are setting the drug costs of this country? They're supposed to be trying to move drug costs down, but we cannot get the information from them on whether or not they really are, or whether they are just setting the prices themselves and passing it on to us. This vertical integration between hospitals, insurance companies, and PBMs, all in the same organization, I feel is threatening to us, rather than creating efficiencies within the system. I'm seeing monopolies coming at us, and we're the ones that are going to pay the bill. Any comment?
I guess I would take a little exception to the comment that PBMs are setting the price. PBMs negotiate the price, but a pharmaceutical manufacturer sets the price. clear as day. They set the price, which is then the benchmark of which Medicaid sets its discounts off of, what Medicare is required to reimburse for that, what is covered, what states have to cover under their Medicaid program, dependent on how that list price is set. So at the end of the day, the problem is the price of the drug, and that's set only and solely by the prescription drug manufacturer. PBMs and their health plans, many health plans actually have the PBM function already in-house. Many of them do. So many of them decided to manage it all within their medical care continuum, so that's not separate. There's no other different kind of profit motive. Health plans partner with PBMs because they can use the girth of their bargaining power against the monopoly and big power of the pharmaceutical manufacturers to try to drive a discount the best that they can get for their clients. So I don't believe that health plans view PBMs being the problem. I think that we view PBMs being our partner in trying to push back on an industry that is completely irresponsible in their pricing. They don't care. They can raise them anytime they want, and they do. I mean, Pfizer just raised prices on 100 drugs in January, and then we pat them on the back when they don't raise prices in July. And so I think we have to be honest about what is driving a unit price, and the unit price is set by the pharmaceutical manufacturer. We actually just commissioned a very large study in coordination with Milliman on pharmacy rebates, because we wanted a better understanding of what those rebates look like for our health plans. It's publicly available on the AHIP website. I would encourage you to all go look at it. And what it definitely says is they took a huge swath of drug data that 89% of drugs do not have any rebate today. And there are protected class drugs, which, if you know what protected class drugs are, protected class drugs are drugs, there are 7 categories, I believe, of protected class drugs that a health plan has to cover all of them in that protected class. The average rebate on a protected class drug is 14%. Where the average rebate on a non-protected class drug is 30%. So monopolistic power makes a difference. Competition makes a difference. And this report also shows that the competition, when there is brand-to-brand head competition, you're getting better prices and better discounts on those drugs than when they run the show, when there's no discount and there's no competition whatsoever. So I think we have to have an honest understanding of what the data says, and not just what we're hearing in the ether. And I think we have to have an honest conversation about what the data shows, which is that the problem is the price. Everything starts with the price, and that everything that we are trying to do is lower that price. And if there is any barrier to lowering that price, we're going to go after it. And that means patent reform. That means passing the CREATES Act at the federal level so that generic competition can be enhanced. We need to have more biosimilars competition in this nation. I mean, we have dozens and dozens of biosimilars are available in Europe. I think there are over 75 biosimilars available in Europe today. We have 3. What is the problem there? I mean, we have to have an honest conversation about competition and what's going on in the drug space, and I'll get off my soapbox.
I want to make sure we have time for our final question, because you've been standing so patiently, but I also want to let Dr. Shiwazawa jump in on drugs.
Well, I believe the Secretary would totally agree with you, though. Integration and that we're seeing can be good, and it can be problematic. And you do see some of the biggest PBMs, Optum, Express Scripts, that are literally merging with pharmacies, for example. And you wonder, is this efficiencies, or are you decreasing the marketplace and decreasing competition? If you can explain to me the PBMs and how they affect the market, you're smarter than a lot of people, because that is one complex operation. And if you look at the blueprint that the Secretary has done that describes that complex interaction between pharmaceutical companies, the PBMs, the wholesalers, and the retail pharmacy, if you can explain that in 30 seconds, you'll do better than most American public can, because this is a complex operation, but it's clearly profit-driven. And with that, you're going to see integration. And these companies are smart. They wouldn't be integrated if there wasn't something in it. Let me just end my remarks by saying Intermountain Healthcare, I will say, is doing an interesting thing. They've joined with 1,000 other hospitals in a not-for-profit organization that is creating their own pharmaceutical company in which they want to produce some certain generics. And partly because of the frustration over drug costs, and in which this hospital group wants to basically go around there and figure out a way to get that more cheaply for their patients. Thank you.
Cindy Rosenwald from the New Hampshire legislature. We just completed an interesting experiment. We're a Medicaid expansion state and have been for about 3.5 years, or 3 years right now. For the first year and a half, we had those individuals participate in managed care. For the next 2 years, we took the 50,000 people and put them into the individual market. That had a really good effect on the number of carriers. Went from 1 to 5, and now it's like 4. The providers loved it because the reimbursements were high, but we found that it was increasing the premiums for the individual market really quickly. And we're on that 20% end of people who don't get a subsidy. In fact, the price impact, we were told, was somewhere around 15%. So starting January 1st, we're going to move those 50,000 people back out of the individual market and back into managed care. And the information we were provided is that it could save our little state up to $200 million a year. Well, save the federal government most of it, but it just would save like half the cost of the program. So where's the right balance between making your individual market more competitive and not making the premiums so expensive because those Medicaid clients are complicated? I guess that's my question.
Well, that's the question all of you are going to have to answer. Because it's going to vary state by state. I mean, you're going to have to kind of play around with it, unfortunately, and figure it out. I would recommend if you do anything and save in any way, lower premiums, make sure you put in 1332, get your pass-through money coming back to the state quickly. I'm sure they'll approve it, right?
Yes.
No,
Final question of the afternoon.
Yeah,
We're the lucky winner.
No, I just wanted to follow up on that question. Mark Siddles from Virginia. So how to use a 1332 waiver. States are coming with different approaches. Is the CMS have a kind of formula for this now? How much money we need to put up? Where's the guidance so that we can get a 1332 waiver quickly through CMS at this point?
So are you talking with respect to like a reinsurance waiver?
Yeah, for the reinsurance program.
So there is not formal public guidance aside from a checklist of sorts so that helps with the application process. But my understanding, and others may be able to speak to this as well, that the feds have been increasingly good about cooperation with state officials in the development phase, and so that...
Well, I think that every state is pursuing this now. I know we are. It's in our budget. So it would be helpful if they gave us better instructions on how to proceed with doing this.
That's a fair point.
It's becoming more and more of a template as more and more states do it. Plus, there's more companies that they've used, more consultants and actuary groups that have done them for Alaska and others, and now other states are using those same ones, using a lot of the same formulas.
So does your group produce information for us?
We have a booklet coming out soon.
Okay. All right. Thank you.
But we'll let your commissioner know.
Great. So please join me in thanking our panel, and thank you for hanging in there with us.
We had a couple of